Good morning. My name is Kinga Budai, and currently I work as a clinical hospital pharmacist in the first department of pediatrics. My supervisor is Csaba Lódi, and my scientific methodology supervisor is Vanda Máté. I am involved in the work of pediatric intensive care unit, so my vision is to improve the effectiveness of antimicrobial therapy and extend the life expectancy of critically ill children. In order to complete my vision, my mission is to improve the antibiotic dosing based on serum drug levels and up-to-date scientific results among critically ill children with or without continuous renal replacement therapy. To complete my mission, the goal of my first project is investigating the efficacy and safety of prolonged or continuous infusion compared to short-term infusion of beta-lactams in pediatric patients. Furthermore, my second project is conducting therapeutic drug monitoring of antimicrobials during continuous renal replacement therapy in pediatric patients. Let me introduce my first topic. Either underuse or overuse of antibiotics can cause severe adverse events in children. For example, the underuse of antibiotics can increase the risk of developing resistance. The patients in pediatric intensive care unit are threatened by multi-drug resistant infection, and these require a higher pharmacokinetic pharmacodynamic target, which can be attained by prolonged infusion of beta-lactams. Meta-analysis among adults showed that prolonged infusion, at least 3 hours, of antipseudomal beta-lactams for the treatment for patients with sepsis was associated with significantly lower mortality than bolus or short infusion, less than 1 hour. Our aim is to examine this question among children, so we would like to evaluate the clinical efficacy and safety of prolonged or continuous infusion of beta-lactams. Our clinical question is, does the prolonged or continuous infusion decrease the rate of mortality or increase the efficacy compared to short-term infusion in pediatric patients treated with beta-lactams? The clinical outcomes will be the all-cause short-term mortality and the therapeutic effect, for example, whether the bacteria could be eradicated, and the length of hospital stay, the adverse events, and the drug levels if they are measured. Our hypothesis is that prolonged or continuous infusion is associated with lower mortality and higher efficacy than short-term infusions. With these results, we can establish a dosing guideline, and its implication can lead to a more effective antibiotic treatment. We made our systematic search in 4 databases. And the final search key contained 1 pediatric, 2 dosing, and 1 antibiotic domain. The full data set consists of nearly 19,000 hits, and after the duplicate removal and the titer and abstract selection, we found 105 articles eligible, and after the full text selection, 32 articles met the eligibility criteria. My second project is therapeutic drug monitoring of antimicrobials during continuous renal replacement therapy in pediatric patients. Continuous renal replacement therapy, CRRT, is commonly used to provide renal support for critically ill patients with acute kidney injury. However, sepsis-associated mortality rates range from 4 to 50%, and need for dialysis is an independent predictor factor of mortality in pediatric patients. In addition, there is a lack of evidence-based dosing recommendations in pediatric CRRT. Only few pharmacokinetic studies are conducted. For example, a small piperacillin tazobactam study showed that only 54% of children with CRRT achieved the required target. So our aim is to identify the appropriate dosing of antimicrobials in pediatric CRRT. The clinical question is, do the current antimicrobial dosing recommendations provide adequate drug levels in pediatric patients treated by CRRT? Every pediatric patient will be enrolled who are receiving antimicrobials and who are exposed to CRRT. The main outcomes will be plasma concentrations, the therapeutic effect, the risk factors which can lead inappropriate drug levels, and we would like to build a population pharmacokinetic model. According to our hypothesis, the current available dosing recommendations do not provide appropriate drug levels and do not take account of influencing factors, for example, the CRRT modalities and settings. With these findings, we can determine a more effective antibiotic treatment. There will be one intervention group. Every pediatric patient will be included who are admitted to PICU and who need anti-infectives and CRRT. And in addition, every anti-infective drug will included who can be measured by the laboratory. We would like to collect risk factors of interest, for example, patient characteristic, the body mass, the kidney function, and serum albumin levels. What concerns the therapeutic characteristics, the CRRT modality, the type of filter and the settings, the effluent rate and the calculated CRRT dose can also modify the plasma concentrations and so the drug dosing. In a nutshell, the primary outcomes will be the percentage of plasma concentrations above plasma therapeutic levels and the proportion of achieving pharmacokinetic pharmacodynamic target. As a secondary outcome, we would like to compare the samples within a 72-hour CRRT period because the lifetime of the filter is 72 hours. Furthermore, the clinical response will be followed and the population pharmacokinetic model will be built. In a summary, my two projects are connected to appropriate antibiotic dosing or anti-infective drug dosing, and the main aim is to ameliorate clinical efficacy. I would like to close my presentation with a nice sentence from Thomas Mann: "Only love and not reason yields kind thoughts." Thank you for your attention.
Thank you for your interesting presentation. I would like to ask you what is currently the recommended pharmacokinetic and pharmacodynamic target of beta-lactams to kill bacteria?
It is a controversial question. There are a few recommendations, but in critically ill patients, the plasma level should be above the four times minimal inhibitory concentrations for the 100% of dosing intervals. So this is the recommendation.
Thank you.
Thank you. Anybody else? If not, may I ask you some this continuous renal replacement therapy mostly will excrete those drugs which is excreted anyway by the kidneys. So do you think that it could be a difference among the drugs according their main secretion place, liver or kidney?
Yes, of course, the CRRT eliminates the drugs which are excreted by the kidney, yeah. And it depends on the binding to the albumin and depends on the size of the molecule. So, for example, under the size of albumin, so under 50 kilodaltons, could be eliminated, the drugs, and the others retains in the circulation.
Okay, thank you. Anybody else? Yes, it's here.
Thank you for your presentation. My question is to your second project. So, which anti-infective drugs can be measured?
For example, beta-lactams can be measured, the meropenem, piperacin, tazobactam, ampicillin, and other types of drugs, for example, vancomycin and antifungal azoles to linezolid, so a wide range of anti-infective drugs.
What kind of sample size do you expect? I mean, so these are going to be quite heterogeneous. I mean, and then how can you put them together? You see, difficulties are just coming as you go deep on this. So did you consider about this?
Yes, the population is very heterogeneous, but we collect every data, and maybe we can make subgroups, or we can assume that some factors, for example, the high rate of the effluent rate is a very big influencing factor, so we can determine these factors in a heterogeneous population too.
Don't worry, I'm not questioning your project. I'm just trying to see the difficulties, that how can you handle the difficulties. And this is probably, I mean, is a process what you actually are going to face in the next couple of months.
It will be difficult, but maybe the statistician will help.
Well, a statistician can solve everything, as
Yeah.
we know.